best natural option we have for lowering cholesterol is this new product that comes from Italy called BergaMet.
Number one, it basically activates the major metabolic switch, which is called AMP kinase. And so what it does then is break down fat and sugar in the gut and in the bloodstream. And so it really switches on the metabolism. So it's an extremely good metabolic regulator. The second mode of action is it works on the HMG-CoA reductase enzyme. So obviously the same enzyme that statins block. But rather than block the enzyme, it modulates it or turns it down. And so it still has some effect on lowering cholesterol, but a better overall metabolic effect. Now, just on that note, I presented a study that I did with the Italians last year at the Australian Cardiac Society meeting, where we showed that rosuvastatin lowers LDL cholesterol 56.5%. But if you cut the rosuvastatin in half to 10 milligrams, so the 20 milligrams, 56.5%, if you cut it down to 10 milligrams and add BergaMet, you get a reduction in LDL cholesterol 52.5%, but a more significant reduction in triglycerides and a better rise in your HDL. So it's overall better for the lipid profile in people who are on statins if you use a lower dose of statin and add BergaMet. So the HMG-CoA reductase effect is an important part of BergaMet's action as well. Number three, it works on phosphodiesterase 3 enzyme. Now, we all know that Viagra works on phosphodiesterase 5, so I'm not suggesting BergaMet is an agent for erectile dysfunction, but it certainly improves blood flow to the organ. Number four, it also works on an antioxidant system in the liver called QR2, and so what it does is I've had a number of patients with metabolic syndrome and fatty liver where it's actually improved the fatty liver as well. Number five, it blocks cholesterol absorption in the gut, rather similar to plant sterols, and that's why we do suggest people take the BergaMet a half an hour before meals, but it really doesn't matter. I still say to my patients, if you forget to take it before meals, still take the BergaMet. So you've got 5 modes of action there, very good for metabolic syndrome, very good for people who are on statins to use a lower dose, because I think if you look at the clinical trials, statins probably cause side effects in less than 10% of people. But if you practice real-world medicine, you realize those side effects are somewhere between 20 to 70%. So I think, yes, statin should be used for people who have significant vascular disease, and can I make the point to everyone that we have 2 of the pioneers of coronary calcium scoring, Professor Matt Budoff and my friend Jim Ehrlich, and Matt actually introduced me to calcium scoring, as did Jim over 15 years ago. And calcium scoring is easily the best way to predict your atherosclerotic risk. So if you have a high atherosclerotic burden, you need to be running your cholesterol lower, you need to be on good global preventative therapy, part of which, of course, is lifestyle modification, but I also think there's another reason for BergaMet there. So for me, the major indications for BergaMet are all patients with metabolic syndrome, all patients on statins to be able to use a lower, safer dose, all patients who are statin intolerant, and I think really anyone over the age of 50 who's interested in keeping their arteries healthy should be on BergaMet as well. Can I say, unlike something like grapefruit juice, where there's significant drug interaction, I've not experienced any drug interaction whatsoever. It works on a different part of the science. I don't think the grapefruit juice does, so there's no concern about drug therapy.
Okay, the question is, we know that one of the mechanisms of statin use, a statin's effect is as an anti-inflammatory. Is there any evidence that BergaMet has anti-inflammatory capabilities?
Yeah, that's a really good question. And part of the presentation I made at the Cardiac Society meeting last year showed that BergaMet specifically works on the LOX1 receptor, which is the receptor for oxidized LDL, which has a very pro-inflammatory, oxidized LDL is very pro-inflammatory. So it certainly works in that mechanism. There's no work on HSCRP and BergaMet that's been done to date, so I can't answer anything there. But the interesting thing I find with BergaMet is that it converts small, dense LDL to large, buoyant LDL. So often you mightn't see a big difference in the cholesterol, but you certainly see differences in the LDL subfractions, and also converts pro-inflammatory HDL to anti-inflammatory HDL, because we're all starting to realize in cardiology that not all LDL is bad and not all HDL is good. And so what BergaMet does is give you the proper profile for the good LDL and the good HDL.
So Ross, the question came that do you suggest replacing patients on statins, and when do you do that, versus just using this to lower the dose of statins? I certainly have my own feeling that if someone has atherosclerosis or a history of cardiovascular disease, then you should be using statins for its plaque stabilization and for its known value in patients with established coronary disease, so what we call secondary prevention. And people like Matt and I extend that to primary prevention in people with extensive atherosclerosis would be candidates for statins. And that's how I have some atherosclerosis, so I take BergaMet, but I do take statins also, hopefully that I'm getting enough plaque stabilization from the statins, not knowing how much plaque stabilization occurs with BergaMet. But Ross, maybe you can chime in on this.
I completely agree. Evidence base for statins is so strong in vascular disease that I think we probably should be using statins in everybody with proven vascular disease, either by coronary calcium scoring or by clinical history. And I think everyone should have a statin in that situation, unless they are statin intolerant. And I don't know about the American population, but in Australia, I would suggest to you 10% of patients are statin intolerant, and they're the ones who should have BergaMet. Now, I'll tell you, now this is an anecdote, it's not a clinical case study, but I had a patient the other day who was in his 60s who had a coronary calcium score of 600, which I'm sure everyone knows is quite significant, and he had an intravenous CT angiogram that showed he had a 50% lesion in his LAD. When I performed a stress echo on him 2 years ago, he had anterior wall ischemia. I then put him on a statin, low-dose aspirin, and BergaMet. And let me say, this man was vegetarian, he didn't have an ounce of body fat, he exercised regularly, but he had genetic cholesterol issues and a strong family history of heart disease. After a month on the statin, he rang me and said, Ross, I can't lift my arms, I can't think properly, I'm not taking the statin. He went off the statin. So he's only on the statin therapy for a month. He stayed on BergaMet and aspirin for 2 years. He came back for a follow-up stress echo a couple of weeks ago, and the anterior ischemia had gone. Now, there is good evidence that BergaMet improves endothelial function. There was a study done in laboratory animals to show that if you induce a balloon injury into the carotid artery of rats and then sacrifice the rats after a month, they have severe atherosclerosis in the carotid artery. If you pre-treat them with BergaMet, that atherosclerosis doesn't occur. And so I'm seeing this quite consistently in my patients, a reversal of arterial stiffness. I'm seeing an improvement in endothelial function as seen by the arterial stiffness measurements, and I'm seeing improvement in blood flow to the myocardium after a few years on BergaMet. So I think it's a really, really important treatment, but I don't think we can say it's a replacement for statins because we have such a strong evidence base for statins in proven vascular disease. But if I can make one point, I do not treat cholesterol, I treat risk. So Matt will tell everybody if your calcium score is 0, your 10-year risk for a vascular event is around 1%. So by taking a statin, you reduce your risk from 1% to 0.8% over 10 years. with a potential of anywhere between a 20 to 70% risk of side effects. So I think we have to be quite mindful of how we're treating people. So 0 calcium score, even with a high cholesterol, I don't think there's any indications to use a statin at all in that situation, unless there's such a rampant family history of severe premature vascular disease, and even then the evidence isn't there that it really helps. But BergaMet is harmless, comes from oranges. I mean, it's the concentrated juice of an Italian orange, and it does seem to have all of these wonderful metabolic effects.
There has been some studies on endothelial function with BergaMet, and we do have a representative here from Atcor Medical that makes the SphygmoCor device from originally from Sydney, Australia, is the company that developed this. What have you found with measuring endothelial function and using the central aortic pressure measurements that you can do with applanation tonometry or using the SphygmoCor device?
Okay, well, let me make that the SphygmoCor doesn't directly measure function, but arterial stiffness measurements, as seen with SphygmoCor, are a very good surrogate marker for endothelial function. And again, consistently, I find that people who've been on BergaMet for somewhere between 6 to 12 months get very significant reduction in arterial stiffness, and that's independent of other treatments. So I've had a number of people who are on statins, and it really didn't affect their endothelial function or their stiffness that much. But when they went on to BergaMet, I've had 50% reduction in their arterial stiffness on this. And I think the SphygmoCor device, which I've been using now for basically 9 years, and I've got experience in about 10,000 patients using the SphygmoCor, is a very good way to monitor your therapy. The best diagnostic test for atherosclerosis, apart from the clinical history, is, of course, coronary calcium scoring. But to me, the SphygmoCor, the arterial stiffness measurements, are the best way to see that your therapy is working. I don't believe there's any indication to do yearly calcium scores. I don't think that gives you any extra information. But if you can see that you're improving arterial stiffness with any therapy, then I think it's a good way to do it in a very non-invasive way. It's completely painless, and it doesn't involve any radiation whatsoever to use the SphygmoCor.
I have a question that's actually 3 parts. One, and I think I can answer it, but I'm going to let you answer it, has to do with, have there ever been any outcome studies? Is it too early for outcome studies with a supplement like BergaMet? Second has to do with its effect on glucose. In patients with elevated glucose, what are you finding? And the third has to do with patients, are there interactions, and what do you think about niaspan with BergaMet? Beyond what we already know about some of the recent controversies in niaspan as far as its efficacy, what about patients who are on niaspan and also want to be on BergaMet?
Okay, firstly, if I start with the first question, there are certainly no outcome studies apart from my clinical 2,000 patients who are all doing very well on it, but you need 5 to 10,000 people on it for 5 years to get an outcome study. And with a safe supplement, I personally don't think that's necessary. With a drug, it's obviously necessary. And I make the point here, I think pharmaceutical therapy is like a Formula One racing car. Gets you from A to B very quickly with the potential of crashing and killing yourself. Whereas supplements are like a bicycle. They'll get you from A to B much slower, but they're much safer. So therefore, we don't need the same rigorous evidence base in large-term mortality studies with something like BergaMet or any other supplement, because basically they're food supplements, they're not drugs. So that's my first point there. No, there are no outcome studies, but I'm not sure there needs to be because of the very good animal data and the human surrogate markers such as endothelial function. That's point number one. Point number two, in terms of the benefits on blood sugar, I'm seeing across-the-board reductions in sugar. Now, let me again make the point. This is called a supplement. It's not a replacement for a healthy lifestyle. So if you can encourage somebody who's diabetic to improve their lifestyle, that's obviously the most important thing. But if you add BergaMet, because it's kick-starting their metabolism, because it's breaking down fat and sugar metabolism, it's improving fat and sugar metabolism, you typically get improvements in blood sugar levels, hemoglobin A1C, and I'm seeing that across the board. Then to finally address the niaspan issue, I have real problems with the way that the whole niaspan research is being conducted. And what I think people are missing out here is the whole concept of undermethylation and overmethylation, looking at the MTHFR gene abnormalities, which occur in around 10 to 20% of the population, and also the use of niaspan in people with metabolic syndrome, because it can often make their insulin resistance worse. So I think we have to target nicotinic acid or niaspan treatment for people who are going to do best on it. But I have a number of patients. Now, I don't have slow-release niacin in Australia. I only have the immediate release stuff, and you say, well, no one can take that. Well, I use that quite commonly. I think it's actually has a better effect on the overall lipid profile than does the long-acting niaspan. But what I do with my patients is I get them to start at a very small dose. You get a pill cutter, you cut it into quarters, and you build it up slowly to 2 pills twice a day, right in the middle of food. And about 90% of my patients can tolerate that. And I'm getting significant improvements with their lipid profile, especially their HDL, especially if I add BergaMet in there to that regimen. And I find this especially for statin intolerant patients, that I'm keeping people symptom-free. I'm seeing a degree of reversal of their coronary disease when I use stress echo to see that I've had demonstrated ischemia and then demonstrated reversal of that ischemia with these sort of regimens. So I think niaspan's been given a very bad press, but I think it's because it's being used often in the wrong people rather than used appropriately. I think that's one of the problems with the HPS2 Thrive study and the AIM High study. I think that there's some big problems with the designs of those studies.
Have you done any CT angiograms on patients who are on BergaMet to see if there's been a reduction or stabilization of their situation, both in terms of lipid-laden plaques and calcified plaques?
No, I haven't done that. I'm not a great fan of coronary angiogram in the sort of patients that I see. I certainly don't see it, I'm sure Matt will agree with me, as a screening test for cardiovascular disease. That's what the calcium score is. So the way I tend to monitor my patients is I get the initial calcium score when I see, just say someone has a high cholesterol and there's some talk about whether they should or shouldn't have a statin. You get the coronary calcium score, you do the arterial stiffness measurements, you appropriately then use BergaMet, maybe with a statin if they have a high calcium score, and then I'll follow that up with the arterial stiffness measurements. So I would certainly not be doing intravenous CT coronary angiograms, because I think the people where the intravenous CT coronary angiography is appropriate are people with, say, a typical chest pain and an equivocal stress echocardiogram. That's where I'd probably go to intravenous CT coronary angiography. But we have one of the world experts on intravenous CT coronary angiography in the audience, Professor Budoff, and it'd be better to get Matt's opinion on that. But I've not seen any work with BergaMet in my 2,000 patients because I haven't done the test.
That was tremendous. We certainly appreciate your insight. With such a large experience, I totally agree with a lot of your comments related to CT angiography. I think we're using it in a research environment, and we're using it for symptomatic patients. So I think that's appropriate not to put it up front and for a lot of your patients who are primary prevention. So the question was, if this person has a good response to BergaMet, is this a lifelong therapy, or is this something that we would use for a period of time and try to transition them to another therapy?
No, I think we should see hypertensive therapy or lipid-lowering therapy. This is lifelong treatment. And I know there's a modest expense with this, but there's a much bigger expense with somebody coming at your chest with a chainsaw, or someone putting bits of stents in bits of metal in your arteries. So to me, to be on a high-quality food supplement that's going to continue with your arterial health is a very wise thing to do. And I take it myself. I've got my family on it, and I've got 2,000 patients on it, and they're all doing well. And I've got to say, there's probably, of the 2,000 people, maybe 20 people have had problems with maybe a very minor gut reaction. Some people do get diarrhea, and because there's not going to be everybody who responds beautifully to any therapy we give. I mean, the consistent pharmaceutical reaction to any drug is probably a 10% side effect rate across the board, and I think statins are much more than that.
I'm sure that as this product is used more, we'll have more and more publications to show its both benefit and where we see the side effects. I think taking an experience from 2,000 patients, from Dr. Walker's experience, helps us in putting it in perspective. But we have to remember that supplements in general don't have the financial backing of a Pfizer or Merck or an AstraZeneca, where they're going to do a 20,000 person randomized trial to show benefit. So I think you're right. I mean, it'd be nice to see more and more evidence, but I don't think we can hold it to the same level necessarily as Lipitor, just based on the product and early in the life cycle. And this drug is earlier in the life cycle than a statin that's been out for 17 or 19 years.
And so I don't treat cholesterol, I treat risk. So I think the first thing always is to establish the level of risk in every patient that we deal with. Now, where's the place of BergaMet here? Again, of course, there's no strong long-term mortality data on BergaMet. I don't know that there ever will be. So what I'm saying to people is, when they've heard this, you can either say, well, look, I want the evidence before I start using it. It may never be there. Or you can do what I've done and tried it in my patients. I've seen the benefits. And again, you put people on a statin, you lower the dose, you add BergaMet, and you get a better result. And I've seen that quite often. And I've seen people who lose abdominal fat on this. I've seen people with diabetes are improved on this. And again, I'm delighted with what I'm seeing, and I certainly won't stop using it. And I'll continue to use it in more than 2,000 patients. And so I would just say to people who are listening to this, everything's a clinical judgment. And as Matt said, there's hardly any medication that any sort of society is going to come out and say everyone should be taking this or not taking this. BergaMet is a very good adjunct to lifestyle modification, which to me is always the most important thing. If you practice the 5 keys of being healthy, which are having no addictions, you cannot be healthy and smoke, drink too much alcohol or snort cocaine. Number 2, try to encourage a good quality sleep habit in all of our patients. Number 3, good quality eating and less of it. Number 4, 3 to 5 hours every week of some form of exercise. And number 5, I gave a TED talk a couple of weeks ago. What is the best drug on the planet? A thing called happiness. So people who try to cultivate happiness in their life. If you add those 5 things together, if you look at all the epidemiologic evidence for those 5 lifestyle behaviours, that's a 60 to 70% reduction in all diseases with no side effects. Whereas we're talking about drugs such as statins, which give you on average a 20 to 30% reduction in one disease. And I think BergaMet is just a very good adjunct to excellent lifestyle behaviour. So I'd like to thank everyone for listening to me tonight, and greetings to all of you from Australia.